Hi, I'm Dave Seaver of Mind Alive Inc. in Edmonton, Alberta, Canada. I invite you to join me to learn about transcranial DC stimulation, its history, physiology, and clinical applications. Transcranial DC stimulation has been around for quite a long time. Back in 1855, Duchenne of Boulogne recorded results with his patients using transcranial DC stimulation. Baron Rockwell in 1871 also reported treating psychological conditions using transcranial DC stimulation. Other people have been involved as well. For instance, Giovanni Aldini was treating melancholy. He was a nephew of Galvani in 1804. 1874, Bartholow did some very interesting work, especially with a patient of his named Mary Rafferty. Mary Rafferty had a cancerous ulcer that formed a 5-centimeter hole in her skull, and Bartholow applied needle electrode stimulation right to her dura, and he mapped out the motor strip, and that's what he's mostly famous for. Other people, now we're getting into more modern times. 1964, Bindman was using DC stimulation on rat brain and was making all kinds of interesting observations. And then currently in 2000, Nish and Paulus, and they are the main promoters of transcranial DC stimulation that has caused all the excitement that we've seen with it in the last 20 years. They're out of Germany. They've been exciting all kinds of parts of the brain. They started with motor cortex. They did a lot of work with stroke. But they've done all kinds of work, and they are also, I say, the main driving force behind the 1,200 studies that exist on DC stimulation to date. As mentioned, much of the seminal work that is really driving the whole tDCS movement at this time was initially all started by Nish and Paulus out of Germany near the end of the last millennium. Here's an example, though, of some of the studies and how this has taken off. When I last published my article in Neuroconnections, it was back in 2012. I've noticed in doing lit searches and stuff for clinical application stuff that research seems to be slowing down since 2012, but it is still ongoing. Now here's an example of some of the studies that have been done involving the cortex. Pretty much every piece of the cortex you could ever stimulate has been stimulated. And research on just the variety of research that has been done on tDCS is extensive. And look at just for cognition alone, general cognition, social attention, reducing fake memory, problem solving, neuroplasticity, insights, decision making, boosting math, learning, and so on. All kinds of behavioral studies. You can see here. Emotional studies, and there are still growing studies on, like, say, bipolar and such, and depression. In fact, there are several more recent meta-analysis studies on bipolar and major depressive disorder. Psychiatric disorders, plenty of work on that. Cognitive disorders, disorders involving pain and language. Aphasia is particularly interesting. And I'll be talking about aphasia more later on here. Sensory studies, boosting sensory acuity and such. Addiction studies. Studies on physiology, on EEG, evoked potentials, theoretical models. In fact, tDCS has really helped understanding some principles involving neurophysiology and taking neurophysiology a step further. Brain function, cerebral blood flow. Studies involving the autonomic nervous system, such as blood pressure, heart rate, and breathing, and peripheral vasomotor activity, and so on. There are several neurotransmitter studies that have been done as well. And other studies, dreams, seizure, MRI, even cerebellum and some spinal cord work has been done. There have been several studies done with animals. And lit reviews, and there's probably all of 50 lit reviews to date. Studies on ethics, comfort, safety, efficacy. Methods, what are the best methods to apply tDCS? And so on. You know, it's been very extensively studied, that's for sure. Now, let's get into the physiology of transcranial DC stim. Well, we're putting a small electrical stimuli to specific sites across the cranium. The electrical stimulus flows through the brain, and from the active electrode to the reference electrode. tDCS primarily affects pyramidal neurons and most likely astrocytes as well. Astrocytes modulate neuronal activity. They have an influence on the brainstem and the norepinephrine production. More research is showing all the time that glia are playing a much larger role in brain function and so on. The anode, which is the positive electrode, it enhances cortical function from 20 to 40% and typically does so within the hour. The cathode inhibits cortical function and again from 10 to 30%. And again, typically most studies have seen this effect happen within the hour. The effect seems to linger for up to about 2 days or so. Now, most of the original 400 or 500 studies looked at tDCS one time only, and they saw those results following one treatment session. More recent studies are looking at 1 week, 2 week, and even 3 week treatment programs to see how they have longer term effects, especially for things like depression, bipolar, and cognitive issues, and of course stroke. And they're finding that yes, after 2 or 3 weeks of tDCS, the effects start to hold much more significantly than a single application would. This is also substantiating tDCS as a use for clinical applications. Here's the theory of operation. Now, this is one of the explanations. There's a few, but this is the primary one that is going on so far. And this explanation is that, as you know, typical neurons have resting potentials in their polarized states of roughly minus 65 millivolts. Pyramidal neurons are also placed in such a way that the dendrites typically are towards the skull and the axons go deeper into the brain. So when we put a positive electrode on the skull and we pass through the skull into the brain, through the neurons, and towards the reference electrode, there's growing negativity as you go from one electrode to the other side. And this negativity influences the membrane potentials of the neuron, roughly bringing it down from 65 millivolts to 55 millivolts, which in turn is going to increase the neuron's likelihood of firing. And certainly a neuron could fire with less dendritic inputs than it would when it's sitting at its normal polarized potential at minus 65 millivolts. Now, this is called neurotransmitter theory, but in actuality, this has been proven. The anode reduces GABAergic activity of the neuron, which excites the neuron. The cathode, or the negative electrode, reduces glutamatergic activity of the neuron. So what we're saying here is this is counterintuitive. Normally, you would think that if we're going to excite the brain, we're probably going to be increasing glutamate as a way of exciting, and if we're going to inhibit, we're going to be reducing GABA. Of course, GABA has a calming effect on neurons. Glutamate excites neurons. And there's always a balance going on between the two neurotransmitters, but it actually works kind of in a backwards way in a sense. We're exciting the neuron by reducing the amount of calming neurotransmitter in a neuron. And with the anode and with the cathode, we are calming the neuron, not by increasing GABA, but by reducing the excitatory glutamate that is within the neuron. So on the electrical side, this is the general consensus on EEG. Cathodal stimulation, which now slows the brain down, it increases delta and theta brainwave activity while reducing beta brainwave activity. So it has an effect of slowing the brain in that sense. Anodal stimulation decreases delta and theta brainwave activity while increasing beta brainwave activity. So you could use this very easily in any case where you might wish to use neurofeedback in this type of fashion. We want to bring down slower activity. and bring up faster activity. This could be the case with ADHD, with head injuries, and so on. And there's certainly certain types of anxiety where we see fast running alpha in the 14 to 18 hertz band. And we could use a cathodal stimulation to take that beta activity down and bring up delta, theta, and alpha as well, at least on a relative level. Studies done on cerebral blood flow. And this is one of the studies done by Zheng. You see at the bottom there's scan numbers, and you see there's on periods, off periods, and so on. Well, in this case, each on period is a 7-minute event, and then it's off for 7 minutes, and then on for 7, and off for 7, and on for 7, and so on. So on the left panel, what we can see here on the left panel, they turn the stimulation on, and you see cerebral blood flow goes up significantly. And then around the scan number of 4 on the x-axis, where you see 4 there, they turn it off. Well, actually, they turn it off before then. And cerebral blood flow falls back down. Then they turn it back on again, and cerebral blood flow goes back up. Turn it off and then turn it back on. But what we do see is that there's a net trending effect where the cerebral blood flow, even at rest, starts to become higher and higher as stimulation is turned on and off. And that might be part of the effects that transcranial DC stim works at. When you look at cathodal stimulation, again, now this is really interesting. During the on portion of cathodal stimulation, it definitely increases cerebral blood flow. So you're going to increase it either way, whether you're using anodal stimulation or cathodal. But we can see with cathodal stimulation that over time, cerebral blood flow diminishes down and down and down and becomes less and less. And of course, that equates with your beta wave frequencies versus delta, theta, and so on. Delta and theta are typically, high delta, theta, and lower beta are typically equated with less cerebral blood flow, and the reverse for increased beta and reduced delta theta is equated with increased cerebral blood flow. So these two studies pair together quite nicely and making that point. Electrodes. Now, electrodes are a big deal, and studies have used all sizes of electrodes: 5x5, which is 25 square centimeters, 6x6, 7x7, and there hasn't been a very good consistency on the electrode size that should be used when doing transcranial DC stimulation. Another problem is that in a great deal of the research, the reference electrode was placed on the contralateral orbit. Most studies use the orbit, some use the shoulder. I'm a believer in never putting the reference electrode on another part of the brain unless we intended to inhibit that part of the brain or excite that part of the brain, depending on what we're doing. But most of the time, probably 99% of the time, you're going to be using anodal stimulation, and you're going to be wanting to excite parts of the brain as part of treatment, which means the reference electrode will be inhibiting. And so I would always use extrasalaphic placements of the reference. In this case, I would use a shoulder, or I would use a neck, or even under the chin. If you're stimulating up at CZ or in the area around the vertex, I typically put a band around the head such that the band is underneath the chin, and I will tuck my reference under the chin. Keep it away from the brain. Now, electrode size is a big deal because people will say, well, we tried 1 milliamp on a 49 square centimeter electrode, and there was no result. Another person could do another study and say, well, we used 1 milliamp on 25 square centimeters, and we had great results. So total current given divided by the electrode size is absolutely important to the successful outcome of using tDCS. And especially when we're using the reference on the contralateral orbit, and we're using the same size electrode as that cathode as we are with the anode stimulating elsewhere, what effects might we have to the prefrontal lobes in terms of inhibiting their function? As it's well documented with depression, pain, anxiety, and all kinds of conditions, if you shut down the prefrontal lobes to some degree, and even more so the left dorsolateral prefrontal cortex, which we treat depression at, if you impair a person's mood or their ability to reason and make good cognitive decisions, their experience of their symptoms is going to be worse. So it's important that we don't mess with those parts of the brain. Hundreds of studies did that before people started thinking, well, maybe we should be getting away from that electrode montage. Meanwhile, finally, Nish and Paulus came up with a study where they found that 17 microamps per square centimeter was the threshold current for sensory-motor effects. And studies suggest that a current density of 40 microamps per square centimeter or more is required for most other areas of the brain. I can say for things that I've been doing, and particularly some cognitive things and depression over F3, I'm often using 100 microamps per square centimeter. And this is called current density. So it's your overall current divided by the size of the electrode, and that gives us current density. And we've got to understand how current density works so you can understand when you're reading research or when you're hearing people talk, marketing a device, you can understand what is really going on, because the overall current that you use is no bearing at all on the effectiveness of your treatment. It has to be with the overall current divided by the size of the electrode. Most people use currents in the 1 to 2 milliamp range. Very common. Now here's an example here of a 20 square centimeter electrode. You can see it's a 4 by 5. There's 1 milliamp. So if you had 1 milliamp and we divided it by 20, you would have 50 microamps in each square centimeter in this case. Think of a pizza. That might be my best example. If you had a pizza and you cut a pizza into 10 squares, assuming it was a rectangular or a square pizza, let's say, and you cut it into 10 squares, how much would each square represent of the total pizza? Well, each square would be 1/10 of a pizza. In scientific notation, each square or each piece of pizza would actually be 100 millipizzas. 0.1 pizzas is 100 millipizzas. 100 millipizzas in terms of micropizzas would be 100,000 micropizzas. So you just bounce the decimal back and forth between standard, milli, and micro. And that is how we do this. So in this case here, we've got 1 milliamp. Now 1 milliamp divided by 10 would be 100 microamps, but divided by 20, it's 50 microamps per square centimeter. And this is important. So supposing we're working with a 20 square centimeter electrode, and we're at 1 milliamp, and our client is not responding very well. What would we do to perhaps get this value up to 100 microamps? Okay, the obvious answer is, well, double your current. If you went from 1 milliamp to 2 milliamps, 2 milliamps divided by 20 is going to be 100 microamps per square centimeter. However, what if you were unable to adjust your tDCS device to 2 milliamps? You could only work with 1 milliamp, and that was that. How could you still get 100 microamps per square centimeter? Well, the answer is take your electrode and cut it in half. If you cut an electrode in half so that instead of having 20 square centimeters, we just have now 10 square centimeters, the current density would double. I notice up at the title here, I say 20 square centimeters. Think of that as 10 square centimeters because that's actually what I'm showing you here. So yes, you could easily double it just by cutting your electrode in half. Now, what would happen if we had 1 milliamp going into one very tiny electrode that was just 1 square centimeter? Well, now you'd have a whole milliamp going through that. And I recommend you don't go for more than roughly 100 microamps per square centimeter. When you start getting in the 200 microamp range, it's pretty easy to burn the skin and have a blister. So be wary of that. What you can do, however, if you are going to work with a very small electrode, most devices have adjustable currents that you can provide to the electrode. So just use a lesser current, 100 microamps, 200 microamps, 500 microamps, whatever will fit with your electrode, such that you don't typically exceed roughly 100 microamps per square centimeter. I hope this makes sense. This is essential for understanding the research and talking to people on a clinical level, because people typically don't think about current density, and current density is the essential measure you have to consider. Not the total current, not the electrode size, but the total current divided by the electrode size. So keep that in mind. And here's an example here of different electrode sizes. Now the electrode size that we use with the Oasis Pro is typically 20 square centimeters. But if you had a 5x5, a 25 square centimeter electrode at 1 milliamp, you'd have 40 microamps per square centimeter. See, ours at 20 will give you 50 microamps per square centimeter. You can see here if you had 2 milliamps going through 25 square centimeters, you're going to get 80. 36 will give you 27 microamps per square centimeter. 49, which is a 7x7 electrode, would give you 20.4 microamps per square centimeter. So ours is actually a little under 20 square centimeters. It's around 17 to 18. And at 1 milliamp, you roughly get 55 microamps per square centimeter. That's what I like to work with as my default. I always start with that. And then sometimes I have to increase the stimulation to higher levels at around 80 or even 110 or so microamps per square centimeter. And our reference is very large. So if you did use it on the head at 1 milliamp, you'd have roughly 19 microamps per square centimeter. But as I mentioned, I prefer to never use the reference electrode on the head. I always use a shoulder, back of the neck, or under the chin as a placement place for my reference electrode. If you're looking at Broca's aphasia, Wernicke's aphasia, or depression, or even motor strip issues, you may want to use two same-size electrodes and intentionally inhibit the homotopic side. And we'll talk about that a little bit more later. Here's an example here of different placements where you could be putting in electrodes. You see on the right-hand picture, that typically isn't what I would do. I'm not sure where we got this from. You see that the reference electrode is on the same side as the stimulating electrode, which is sitting pretty much over the motor strip. I would typically put that reference on the right-hand shoulder, the contralateral side. So not on the same side, but on the contralateral side. At the time, we were experimenting with using ipsilateral and placements of the reference, and it was working, but as a general rule of thumb, I think it's better to have it on the contralateral side. So you go through the pyramidal cells more straight and rather than hitting them at a diagonal. That's my general rule of thumb. So there you go. And if you're right at the vertex, then I would typically put the reference under the chin. And if you're working with frontal areas, I would be using typically the neck as a placement. We have a long skinny electrode that is about 4 or 5 centimeters long, but only a centimeter and a half wide. And that allows us to hit FP1, FP2 simultaneously, in which case I would use the neck. If we were doing just FP1, I would use right shoulder. FP2, I would use left shoulder. Same idea with F3 or F4, I would use the contralateral shoulders. But with the long skinny electrode, you can do FP1 and FP2 simultaneously, which makes treatment faster if you're treating prefrontal issues. And then I would use a neck reference. In the case of working with the cingulate with OCD, and we get a lot of people with obsessive compulsive disorder who have slow cingulate, probably caudate under CZ. And in that case, I would use the skinny electrode and I would place it along FZCZ or CZPZ, and I would use the reference electrode under the chin. Some of the side effects that have been reported on transcranial DC stim, there's been a lot of research on side effects. A lot of people report mild tingling, which is typical, and it's not an issue at all. Some find that there's some fatigue after. I really believe that whenever you're stimulating a brain, it's important to give them a big glass of water 20 minutes or so prior to doing the actual treatment. And this is whether you're doing neurofeedback, whether you're doing entrainment, tDCS, CES, or anything. Drink a big glass of water. Many clients with mental health issues have a tendency to forget to drink water anyway, and they're a little dehydrated. And we do find that when you're stimulating the brain with any modality, sometimes people can get mild headaches. But if they drink a glass of water, a big glass of water 20 minutes prior to treatment, then they don't get the headaches. Light itching, slight burning, or mild pain, about roughly 20%. It's variable in the research. Some people do get the mild headache, as I was mentioning, and trouble concentrating right after a tDCS. Well, it can tire a person out a bit as it's working the brain, so that can happen, yeah. But over time, that will improve, and it'll go away. Typically, if you're working with an EEG, you can equate it to Brodmann areas, and this website shows Brodmann areas. Of course, you can go online and you can find Brodmann areas all over the place, and it'll help you determine which part of the brain you want to place your electrode. All of a few hundred studies have been done using tDCS in the treatment of stroke. And in my opinion, if you can use a technique that does an excellent job of providing recovery from stroke, then it's a good technique. Here's some things about stroke. These are some of the original studies. In fact, almost the first 100 studies were mostly done on motor recovery in stroke patients. In this case here, if the person had hemiplegia on the right-hand side, let's say, then they'd be using the anode along the left sensory-motor strip. The motor is in the anterior side. You can see where the anode is, and the sensory is just behind it, a little bit posterior in the parietal area. Now you can use the standard diagram of the homunculus to see the different parts of the body in case you have a stroke that is more specific to a body region. And this will help you decide how to give you a guide as to how to place your electrodes. And pictures of the homunculus are all over the internet. Print one off and you can use it as a guide. Here's an example here of a study done using tDCS in the treatment of motor issues. Now in this case there's a sham, there's a tDCS group. The sham group is in green, tDCS is in blue. And they're looking at the upper extremity Fugl-Mayer, or UEFM, and also the Wolf Motor Function Test. So we're looking here at using tDCS versus sham on the left-hand side with the upper extremity Fugl-Mayer test. We can see here that the tDCS group had much better mobility with their limbs based on that test as compared to the sham. When you look at the Wolf Motor Function Test, this is a timing test. How fast can you do something? So in this case, we're seeing that those who had tDCS were doing things faster. That's why we see the downward graph. It took less time than the sham group. So that's what that's about. Now, some of the issues that arose in tDCS research over the last 2 decades had to do with where do we place the electrode. And of course, all the original studies, they were placing the electrode over the lesioned area. And then it came up that, well, maybe that's not the best place to put the electrode because there's a lesion there. These neurons are no longer functional. Let's put them over the perilesional area. And then it came out later on, well, maybe that's not so good either because the homotopic, or the mirror side of the brain on the other hemisphere, likes to take control over the damaged area. So perhaps if we put the cathode over the homotopic side, it would prevent that side from trying to hijack the lesion side, and you'd have better treatment outcomes. And so it was shown that, yeah, you could literally treat the other side of the brain with the cathode, and it would actually speed up recovery of the lesion side. And then it came out of that maybe we should be putting the cathode on the homotopic side and we should be putting the anode on the lesion side. Yeah, better results again. But sometimes it didn't work. And then finally, in this study here with diffuse tensor imaging, it was found that, and you can see in the upper left panel when we're looking at the ascending tract here, what's happening is if they put the anode over this section, it's not going to work because the ascending network, or the tract network that runs down, is also very, very damaged as a result of the stroke. And you just can't get recovery from that, even if the neurons are in pretty good condition. So they found in this case, you were better off you can see on the right-hand side where the right tract, of course, is in very good shape. And so it was found better off to be, in this case, putting the anode opposite side, the homotopic side, and encouraging it to hijack the lesion side, in a sense, to gain control, because you're not going to recover it from the lesion side. But when you look at the bottom 2 panels, We see in this case of stroke, the ascending tracts are in excellent condition. In this case, then, it would make more sense to put the anode over the lesion side, in which case is the left, and put the cathode on the right-hand side to prevent that homotopic side from trying to hijack the stroke side. And so, yes, so now you don't have diffuse tensor imaging, of course, not everyone can get their hands on that. And if you can, this will help you determine if you should be putting the anode over the lesion side and cathode on the homotopic, or just putting the anode on the homotopic side and the cathode on probably the contralateral shoulder. But anyway, if you're doing treatment and it's not working, then I would suggest that you would just give this a thought and perhaps put the anode on the other side. Here's another study that shows when tDCS excites the brain, you should engage in therapy relating to that side of the brain. Now, when you look at these two panels of trained nouns and untrained nouns, you can see here that for whatever reason, some of my letters for active and sham are in the wrong places. That active should be in the left side, on the left bar, and the sham should be a little more left. And on the right-hand panel, we could see that things should be shifted to the right more. So just keep that in mind when you look at this panel. This shows with trained nouns and untrained nouns that if you do trained nouns and you look at response time in milliseconds in this case, that the tDCS group had a faster response time. So in other words, less milliseconds to get their speech out. Whereas when you look at the sham side, the time period was quite long for trained nouns. So training definitely has quite an improvement. When you look at untrained nouns, where there was technically no speech therapy provided, immediate post-testing or 3-week post-testing, there was really no difference at all. So, and I've seen this time and time again, when you're doing tDCS, work on the task associated with that part of the brain that you are treating. And because you can do tDCS eyes open, it's easy to be doing brain games, tasks of all kinds while you're getting tDCS. And then have them do those also, that training, when they go home. So as I mentioned before, originally they were just putting the anode over the lesion area, as you see in the left brain picture there in panel A. Then they started putting cathode over the homotopic areas, and that still had improvements. Then they put anode over the perilesional area, which was better. Anode over the perilesional area and cathode over the homotopic area was better again. And then with diffuse tensor imaging, they found that there's a discriminant depending on the networks below the cortex is another determinant to decide if you should really be working the perilesional area and cathode over the homotopic, or maybe just putting the anode over the homotopic area and skipping the lesion area entirely because the networks are knocked out underneath the cortex. So if the stroke is small and perilesional areas are intact, then excite the perilesional areas with the anode while inhibiting homotopic areas so they don't try to hijack the lesioned areas, the stroked areas. If the stroke is large and perilesional areas do not exist, then stimulate the homotopic areas with the anode. So keep that in mind. Give that some thought. Keep it in mind. I'm going to show you different electrode placements for different maladies that you're going to see day to day in your practice. Here we're looking at depression. Now, what I find typically is that many of my clients have had long-term depression spanning many years and a lot of cortisol damage, especially if there's childhood traumas involved. There's cortisol damage to the prefrontal lobes. On an EEG, it typically shows up as high alpha on both the left and right prefrontal and frontal areas. So my thought is, why would I put a cathode on the right-hand side at F4 if it's already functioning poorly? Just that F3 is functioning worse if I'm going to treat depression. So typically, with long-term depression, I'm going to put the anode on F3 only, and I'll put the reference, the cathode, on the right-hand shoulder. If it's acute depression, where you might see an overactive right dorsolateral prefrontal cortex at F4, I might put the same size cathode as the anode on F4 in those cases, but I need to confirm this with a QEEG before I would proceed. And that's what this looks like here. This is a study done by Wernicke, where he was using this to treat cravings and depression. Again, I wouldn't follow this model. I don't like putting a cathode on a part of the brain that is already functioning poorly and make it function worse, unless I had a QEEG to show that it was actually overactive. Now, what was interesting, when he did it this way, he had very good results on reducing alcohol and food cravings. When he reversed them, as we saw kind of with that cerebral blood flow example, when you reverse electrodes, you still will increase cerebral blood flow to some degree. So when he had them reversed and had the cathode on F3 and the anode on F4, he still had improvements. They weren't as good, but he still had improvements. So if you accidentally did reverse your electrodes, don't panic. Put them straight the next time, but you are not going to probably cause any harm. You just won't have as good a treatment effect. Attention. I use the long skinny strip that we have, which is about 5 centimeters long and maybe about 2 centimeters wide. Yeah, it's got to be all of 2 centimeters wide. And I put that right across above, between the eyes, above the eyebrows, typically at FP1, FP2, and I'll use a neck reference. Insightfulness, and this is a clever study done for insightfulness, and with clever little exercises, and they found putting the anode on the right temporal area and cathode on the left temporal area improved insightfulness and problem-solving ability. These are pretty common placement areas for socialization. Many people struggle with facial recognition, facial expression and body language, and it's typically all in the right temporal parietal area. And we've been using the anodal stimulation there to help people improve their social ability. This was a study done on math out of England. And again, one of the questions that I ask is, why would we put a cathode over, in this case, a P3? Could we be causing language impairments when we do that? And I did query the professor involved in the study and suggested that, if they do future studies, they should look at what's underneath that cathode in case there are impairments. Vision. This showed that discrimination of different slight variations in shades of colors were improved with this electrode arrangement. And you could use that maybe if you want to become a better interior designer. When you look at all those Pantone shades of paint, there's 1,000 shades of pink alone, so you might be able to discriminate better. On a military level, if you're looking down from your jet plane and you're looking at camouflaged areas in heavy, dense jungle or forested areas, it might help you note slight shades of coloration that'll help you to depict the difference between what's camouflage and what is real foliage in a forested area. Auditory pitch. If you can't sing in the choir because you just can't have your auditory pitches off, and then this study showed that when they put the anode over T3, pitch discrimination went up considerably. This is an example here of enhancing motor ability and reducing pain. And this is how they did it in the old days. They were using, say, electrode A1, anode over the left motor sensory area with the contralateral orbit of the eye, and they were getting results, or they could do it the other way around, with putting the anode on the right sensory motor area and the cathode over the left orbit. And they were getting results with these techniques. I don't like these techniques. I don't think a cathode should be put over the prefrontal lobes ever, unless it's been warranted by an EEG or QEEG. But Mendonca said this doesn't make any sense. So we're putting cathodes and stuff over the prefrontal areas. Why are we getting reductions in pain? Because there's quite a few pain gates in the cingulate area. So she tried a technique where she put anodes over the prefrontal areas and a cathode on the neck. And this is a good technique, in my opinion. She also tried cathodes over the prefrontal areas, and they did not work as well. It did work, but not as well as anodes. So I would say cathodes aren't working as well, and anodes do work better, so you should use anodes anyway, but especially because you're working with prefrontal areas, you may as well work with anodes and improve their cognition, their short-term memory, and reasoning ability, and so on. Broca's area in stroke, as we've been discussing already, is put the anode over Broca's area, roughly at F5, and put the cathode over the F6 area. A similar idea when treating Wernicke's aphasia. We'd be putting the anode again over the T5-ish area, P3. and the cathode over the homotopic area, P4T6 area, and doing it that way is the most successful outcome, according to the research. Well, that is it. I hope you have enjoyed my lecture on tDCS. It's been fun. I find neurotechnology and tDCS to be particularly exciting. I've seen remarkable improvements in some of my clients, and I wish you the best in treating yours.